Dear colleagues, I am Filippo Crea, the new editor-in-chief of the European Art Journal. Welcome to the first EHJ Dialogue. This is a new feature of the journal which fulfills two important goals. First, a global reach in the 5 continents, and second, not only information, but also interaction with our readership. We will have a dialogue each month with leaders in cardiology from the 5 continents. The registration will be free. As you know, dialogue is a Greek word, which means through a conversation, and was successfully used for the first time by Socrates as a way to reach the truth through the conversation among 2 or more persons. EHJ dialogues reflect precisely this philosophy, and they are a conversation among journal board members, authors, and readers. Thus, you are invited to ask questions. A quick note on the technical side. I've been thrilled to find out that we have many more registrations than we can accommodate by Zoom. My editorial team and I, therefore, decided to live stream via YouTube and engage with you via the chat. Please ask your questions and note that even if we don't respond here, we will keep a record and might use them for future dialogues. Finally, please remember, like your newly created channel, subscribe to it, and select the bell in order to be notified of new content. Well, it is now my great privilege to ask Professor Libby, Executive Editor of the European Art Journal, to start our first dialogue with Professor Braunwald. Peter, please.
Okay, yes, I wasn't allowed to unmute there. Well, hello everyone. This is very exciting to launch this new series, and we're privileged to have Dr. Braunwald with us, as we were at the virtual experience of the recent ESC meeting that was in the ether, not in Amsterdam. And there was a special session that was devoted to the passing of the baton of the editor-in-chiefship of the European Journal of Cardiology from the superb and extraordinary leadership of Thomas Lucia to Filippo Crea. And the group could think of no one better to keynote that session than Dr. Braunwald. And Dr. Braunwald chose as the topic preparing for the 400th anniversary of the birth of cardiology. So Gene, can you tell us why you dated the birth of cardiology about 400 years ago?
First of all, I want to thank Filippo and you, Peter, for inviting me to participate in this dialogue, especially the first dialogue. And so it's a very special honor for me. In thinking about the passage of the editorship of this very important cardiac journal from Tom to Filippo, I tried to think about the broad span of cardiology, and particularly the role of Europe in this. And since I spent the first 10 years of my life in Europe, I have a special affection for the continent. And what came to my mind was that cardiology was born in Europe, and the father of cardiology, of course, was William Harvey. So William Harvey was an Englishman. He attended Cambridge University. He decided he wanted to be a doctor, and he wanted to go to the best medical school in the world at the time. And that was the University of Padua. And he came under the influence of an extraordinary faculty. When he completed his training, he moved back to England. He went to London, and he had a very distinguished career. And in his career, at the age of 50, he published a small book called De Motu Cordis, in which he laid out the circulation. It was not known before Harvey exactly how the blood moved around and what the role of the heart is. And he put it together. And I consider this a high point of science in the Renaissance. And I consider that there were three giants in science that were at about the same time: Galileo in astronomy, Isaac Newton in physics, and William Harvey in biology and medicine. And so the 400th anniversary of his publication will be in 2028. And then I try to imagine what Filippo and his colleagues and you all are going to be publishing between now, the handover from Lucia to Crea, until the 400th anniversary. And then I began to think about this, and that's how I came to discuss William Harvey. Okay.
Amelia, I think you have to unmute Filippo.
Another contribution from Italy came by Malpighi from Bologna, because he discovered the missing link between arteries and veins, the capillary circulation. So Italy has been present all the time.
So, Gene, in your talk, you took out your crystal ball and you talked about 4 innovations that you thought were going to be important in the coming years in cardiology. And the first one you talked about was primordial prevention. And what did you have in mind about primordial prevention? Why is it important?
I think primordial prevention, I think many people know what it is, but I think probably best to define it. We all know what secondary prevention is, and we all know what primary prevention is. Primary prevention is treating a patient who has risk factors for a disease, especially coronary artery disease, and to dampen down those risk factors like hypertension, cholesterol, and so forth. Primordial prevention is to go back further, is to prevent the development of the risk factor. The risk factor develops the disease. Primordial is prevent the risk factor. And there we have to basically go increasingly to younger people and to childhood. And I think what's very clear is that risk factors like hypertension, hypercholesterolemia, obesity, even smoking are started. There are tracks of this in childhood, and they continue to track. So if you take a group of 1-year-olds and you look at the distribution of blood pressure, that distribution pretty much holds when they're 20 years old. So I think that what we need to do in primordial prevention is to have good lifestyles. And I think that's where the focus is. And about 5 years ago, the American Heart Association came up with 7 lifestyle advices. It has to do with the usual things: diet, smoking, the avoidance of obesity, and so on and so forth. And one of the interesting analysis that came from this, there were 7 factors. Cardiovascular disease was a function of the number of misses that you have. You got 7 scores. The worst is to have 7 go wrong, and the best is to have none. And there is a linear response with cardiovascular outcomes. So this is incredibly important. Now, what's exciting to me now is that primordial prevention is going to be earlier and earlier, and it's going to move into the prenatal period, because now it's become clear that pregnant women who are obese, who have diabetes and have hypertension, although the mechanism hasn't been quite worked out, their offspring have an increased risk. And of course, the other thing that I think will be seen during the next 8 years in the European Heart Journals, other cardiac journals, is going to be the earlier analysis of the human genome, of individual genomes, because it's not just simply single genes that go astray, but it's the entire panoply of evaluating risk. And that could be done in the first year of life. And so I think there's a lot to be done there. And this could have a very profound effect on our specialty.
So, Gene, you talked about lifestyle. We all agree about lifestyle and the 7 deadly sins. But what about drug therapy? Do you think that there's going to come a time when we're going to be treating young people, even children, with drugs?
I think it is likely. An example of a drug. I mean, I certainly would not recommend putting statins into the drinking water so that everybody gets their statins. But I would say that if you have a child who has maybe in the 90th percentile of 1-year-olds or 5-year-olds, has the top 5 or 10 percentile of LDL cholesterol, I wouldn't say that you might not consider ezetimibe. Ezetimibe, we just completed a trial called Improve It in the TIMI group, and it was a 19,000 patient trial. It's the only drug trial that I've ever done where there was not a single adverse effect to the drug. And the other thing about ezetimibe is that it's very inexpensive. It's generic. So to take a drug that has no side effects and that is, while not very powerful, certainly reduces LDL by half of a millimole, I think is something I would consider for the upper reaches in primordial prevention. Now, I don't think it's going to happen to many people, but I don't exclude that. Certainly, when the statins came along, nobody thought that it would be used in primary prevention. But we learned, and obviously, statins are key in primary prevention. So I think that some drugs may find their role in pediatrics.
So, Filippo, I think a question has come in on chat that you might ask Dr. Braunwald about.
Let me unmute first. Well, as I said, this is a very interactive meeting, and we have a question from the audience. A question asked by René Botnar from London and Anno Tan from Amsterdam. And the question is, do you see the enormous technological advances we are experiencing is distancing doctor from patient and interfering with the personal bond? Is this a risk in your opinion?
I think that's a terrific question. And I think that there is a risk, but I think we can get around it. First, a few seconds of history. When the great French cardiologist developed the stethoscope, it became clear that it was not necessary to put the ear on the patient's chest. And And so a tube was created, and people, clinicians, said that that tube, which the doctor put his ear on one side and it was placed on the patient's precordium, you could hear the heart sounds. What wasn't clear was that the purpose of this was to enhance the information that the physician could get and be a better doctor. But people complained. They said, this new technology is getting in the way. And this has occurred repeatedly in the last 200 years. Every time a new device comes along, people say, this is going to take us away from the patient. And certainly we have examples of, particularly in young physicians, patient comes in to the examining room and they look at the computer and they look at the results of the echo and of the other imaging and the blood tests, and they don't look up to the patient. The purpose of this technology, all the way to artificial intelligence, going from the stethoscope all the way to artificial intelligence, machine learning, is to enhance the doctor's contact with the patient. Give the doctor more information so they can concentrate on the patient. And that is the job of cardiologists. We have to insist on that so that it is not done mechanically.
Well, thank you. This is very, very reassuring, in particular for our young colleagues. Peter, you have other questions, I guess.
Yeah, well, one of the other topics that Dr. Braunwald outlined looking forward was inflammation. And we heard at the virtual version of the ESC meeting about a new use of an old drug, and that is colchicine. We had the results of the Colcott trial, and now we have the results of the LODO-CO2 trial that were presented at the virtual experience. So what are the implications of those findings for practice and inflammation in general?
I think that the issue of inflammation and the role of inflammation in cardiovascular disease, especially in atherosclerotic disease, has been around for a long time. And Professor Rudolf Virchow, in the middle of the 19th century, considered atherosclerosis to be an inflammatory disease. And then things died down. And toward the end of the 20th century, you, Peter Libby, called attention to this. You awoke this sleeping giant and did some very, very important work on interleukin-1 beta, and then working also in your group and together with many of us at the Brigham, Paul Ritke, measuring, easily measuring CRP with an excellent method. It appeared that there was evidence that, that inflammation did play an important role. But it was circumstantial evidence. It was beating around the bush, as it were. And then Paul Ritke and you, Peter, led a trial, and others led a trial called CANTOS with a monoclonal antibody in patients whose LDLs were controlled. Canakinumab is the name of the antibody. And this is a landmark trial. It was a large trial and a mega trial, and it resulted in a reduction of adverse cardiac events in patients with coronary disease. Well, that was that changed all of the thinking in this field. For complicated reasons, the sponsor has decided not to get regulatory permission for this drug, but it didn't stop the field. It got the field started, and now we are seeing the benefits. We're seeing the benefits with colchicine. Colchicine has been around for a long, long time. It's been known to be effective in acute gouty arthritis. It has been used for a couple of decades in acute pericarditis. And so now we have two trials in coronary disease. The first one, Colcott, published almost a year ago in patients post-acute MI, and the second one in patients with chronic arteriosclerotic cardiovascular disease. And both of these were significant and were positive. And the drug is basically well tolerated. And I think the combination of CANTOS and these two trials have really opened the door. I think we are going to have a class of drugs. And I think that what the European Heart Journal is going to be facing in the next 8 years before the great celebration is more of these drugs and a refinement. In other words, let's think of the anti-inflammatory drugs like diuretics. We couldn't function with a single diuretic in order to treat patients with heart failure and patients with edema. We need to have many arrows in our quiver to handle this. And of course we do as far as diuretics are concerned. And I think we're going to see the same thing with anti-inflammatories. It's not going to just simply remain with colchicine. There are going to be others. And I think the trick is going to be to give the right drug in the right dose to the right patient. And it's going to be seen in secondary prevention, because these two colchicine trials were secondary prevention trials. Also going to be seen in primary prevention. Of course, the safety there becomes even more important. So I think this is going to be very, very interesting during the next few years.
Great. Filippo, it looks like there's some more questions that come in on chat. You need to unmute.
Okay. Can you hear me now? I guess yes. Well, yes, regarding treatment, we have an interesting question from Panos Vardas. He says, as many diagnostic and therapeutic problems in cardiovascular medicine have been solved, do you believe that industry will invest further money in cardiology?
Absolutely. I think that when we say that a lot of the problems have been solved, I think if you look at textbooks of medicine, textbooks of cardiology through the last 100 years, they always start out by saying, we have learned a lot, we know everything, but there's still a few things that are left. And I think we're at the same place now. I would not, with respect, I wouldn't agree that the problems have been solved. There are more people who die of cardiovascular disease. It's still the #1 cause of death in adults, in the world. And so we have a long way to go. But I think, for example, the two things we discussed, primordial prevention, which is not that simple. I mean, the concept is simple, but the execution is not going to be simple. We're going to need industry for that. And certainly we need industry to give us that whole array of anti-inflammatories. So what they did with CANTOS and with colchicine is they opened the door. And I think that industry, see, in academia, we can do a lot of things, but we can't produce a new drug. We can test a new drug. We can get ideas of where they should go, but we can't take a drug and get it registered, at least not in the United States. And therefore, I think industry is an essential partner. It's an essential partner. And as long as cardiovascular disease is an important disease, and that certainly is going to happen in the next 8 years, and during your editorship and maybe beyond, we don't have to worry Unfortunately, cardiovascular disease is going to be around. I think it can be reduced, but we need a partner, and that partner is industry.
Teamwork works well all the time, in this case, between scientists and industry. There is another question from the audience, prevention again. What about the poly pill? Are you in favor of it? Can that help? What about?
Okay, what? Hear the question, please. Wait.
Okay, so Filippo, can you repeat the question?
Yeah, the question is from the audience regarding prevention. What about the poly pill?
What about what?
Poly pill.
Poly pill.
Poly pill.
The poly pill.
Poly pill. Okay. I have mixed feelings about the poly pill. I think that the idea is interesting. I think that the execution is difficult. I think that to put everything for every patient into the same pill, or even to have two poly pills, I think is a problem. I think maybe for certain very, very primitive organizations where drugs is not available, perhaps it could be used. But I'm not a fan of the poly pill.
So we also have a question from Lizzie Brewer in Amsterdam, and wants to tap into your wisdom, Gene, that you've managed to stay on the cutting edge of cardiovascular medicine and science for many decades. And how do you do it? How do you see around the bend? And how do you identify the most important problems, the novel problems, and attack them? What kind of advice do you have for our younger colleagues for how to emulate the success that you have had?
First of all, I would say that I go to the right place at the right time. And I have been very fortunate in my training, and then subsequent to my training, the institutions in which I have worked make an enormous difference, and the colleagues that you develop. To me, what's been most important is to be surrounded by young people. As I get older, I get my ideas from younger people. Now, I don't know how many people are aware of the fact that you, Peter Libby, were in my laboratory in California when you were a medical student. And I have followed your career. We have worked together at times we have worked next to each other. But I have paid a lot of attention to the young people. So and in working with the younger people and in picking their brains, I try to sort out what's new and what direction to go. A lot of this is intuitive because you hear a lot and you read journals, and there are so many facts that are thrown, and you've got to try to choose the best one. And the best ones usually come from the youngest colleagues that we have. And the institutions in which I've been privileged to work, and I have to say privileged, have attracted outstanding younger people. And it's from them that I pick up these ideas that continue to drive me.
So, Gene, you've taken a historical perspective. You've been Janus-like, looking forward and backwards in your talk at the ESC and in this interaction. So you know William Harvey well. Can you tell us, did he have an aha moment that led him to postulate the existence of the circulation, or was this an evolution? Was it pure inspiration?
You're correct, Peter. I know the life of William Harvey well, and although I'm fairly old, I was not alive at the time of Harvey, so I didn't know him well personally. But it is extremely interesting to follow how his mind worked. One of the things one of his professors in Padua was Fabricius Acquapenti, and Acquapenti discovered the valves in the veins. He was an anatomist. He was professor of anatomy and surgery, and he discovered the valves in the veins. When Harvey began to think about the circulation and how it might operate, he found that the valves in the veins were always set in a way to allow the blood to flow towards the right atrium. Didn't matter whether the veins were in the foot or in the cerebral circulation. Everywhere, or in the mesentery, the valves in the veins prevented the blood from going in any other direction. Well, that was an aha moment. With that idea, and why Harvey was such a great scientist, he had the idea, he developed a hypothesis, and then he tested the hypothesis. So he was the first experimentalist in medicine. Everybody before him, all of the greats before him, Galen, Vesalius, they were observers. They were terrific observers, but they weren't experimentalists. And he was an experimentalist as well as an observer. And I think that is how this tremendous idea and the tremendous specialty really was born.
Well, let's fly from the past to the present and future. One interesting question coming from the audience is about chip. You are one of the protagonists in this new field, a fascinating field. What do you see in your crystal ball for the future?
That Peter is really one of the leaders in this field, and I'm a loyal follower. And I think that it basically amounts to clinical hematopoiesis, somatic changes. And CHIP is an abbreviation, and it's easy to speak about it because the other words are very long. But I think this is an extraordinary development because we thought until a few years ago that we knew all about the risk factors for coronary disease and cardiovascular disease. I mean, you know, the Framingham study buttoned down cigarette smoking, hypertension, cholesterol, diabetes, and of course, people had done that before Framingham. So the risk factors for coronary disease have been solid. They've been with us for 60, 70 years. And what we've known is we have to attack the risk factors, primary prevention, primordial prevention. And now, out of a clear blue sky, comes another risk factor. That's just as important. It's seen primarily in the aged. It's genetic. The genes, the important genes that are responsible have been described. It increases coronary artery disease in the elderly, almost doubling it. It increases all-cause mortality by 40%. This is a big deal, and you are going to deal with it a great deal during your distinguished editorship. I think that we don't have good treatment for it. People have ideas, and I think that we should really ask Peter to respond to it because he's one of the leaders in this.
Well, Gene, this is your show, but I think because we're coming around the appointed hour, maybe Filippo has a final question for you about how we're going to be interacting in the future in the age post-COVID.
Well, we are going through this difficult time with COVID. It's changing our life. So let's look at the future. Do you think that COVID will affect the way we practice medicine and we teach medicine? And if this will happen, will be for the worse or for the better? Are you optimistic about it?
It's a mixed bag. You could say the glass is half empty and it's half full. What I see with COVID now in the United States, the glass is even more than half empty. I think our situation is extremely dangerous at the present time. And, but I think the glass is also half full because we have endured a lot of bad periods in our history as the human race. And in the United States, we have come through the worst civil war that you can imagine with the abolition of slavery. So I think that we will ultimately get over this. And when we get over this, which is not going to be very, very quickly, I'm afraid, when we get over this, probably with a superior vaccine, it's still far away, not as close as some people would like. I think there are certain aspects of the way we communicate, whether we work at home or whether we interview patients by telehealth. I think a lot is going to change that could be very, very positive. So I think that in the long run, I hope to live long enough to participate in the long run. In the long run, it will be positive, but in the short run, it's a problem. And I am looking at the numbers on a daily basis. I'm seeing problems not only in the United States, it's very bad in the United States, but I'm seeing problems in Europe as well. I follow the daily mortalities, and I don't like what I see. I don't like what I see. It looked very, just the past month has looked worrisome. So, quick answer. The glass is half empty for the near future. The glass is half full for the long term.
Perfect. Well, I'm sure that confidence in science and teamwork will allow us to go through this difficult moment. Well, this concludes our first dialogue, and I'm happy to announce the next dialogue will be on October 29th at 17 Central European Time. In the meantime, let me thank Professor Braunwald, this giant of cardiology, for the time dedicated to the European Heart Journal, and Peter, Professor Libby. Peter, thank you for your excellent contribution as usual. EHJ Dialogue couldn't start in a better way. Thank you again, and we will meet again in 1 month.